Good afternoon, everyone. My name is Delia Prieto, and I'm the Director of Research at the COPD Foundation. My colleague Kristen Willard and I have been planning this event for a couple of months now, and we're excited it's finally here. On behalf of the COPD Foundation, I'd like to thank you for joining us today. I hope you find this event useful in understanding the basics of bronchiectasis and NTM. Before we get started, just a few housekeeping notes. I wanted to let you know that today's program is an audio program only. There's no video portion. And during the program, we'll have 2 question and answer sessions during which you'll be given the opportunity to ask questions of our expert speaker. Aside from those designated questions and answer sessions, your telephone lines will automatically be muted so that you don't have any unnecessary background noise. Our operator, Kathy, will tell you how to pose a question when we start the Q&A sessions. This call is being recorded, and we'll let you know where you can access the recording in the coming weeks. Now let's get started. We're excited to have Dr. Kevin Winthrop of Oregon Health and Science University as our expert speaker today. Dr. Winthrop is a professor of public health and associate professor of infectious diseases and ophthalmology at the School of Public Health and School of Medicine at Oregon Health and Science University in Portland. A former infectious disease epidemiologist at the CDC, Dr. Winthrop has co-authored more than 170 publications. He's widely sought for his expertise and has studies in the He is widely sought for his expertise and has served as a primary or senior investigator in many clinical or epidemiological studies in his field. In addition, he is a member of the graduate faculty at OHSU, where he mentors public health students, medical students, and physicians in postgraduate training at OHSU. And at OHSU, he directs a national referral center for chronic chest infections. Thanks again for joining, and I'll now turn it over to Dr. Winthrop.
Well, hi guys, it's Kevin Winthrop here. Thanks for having me on, and I appreciate it. And thanks for letting me give a talk without slides, because it's a hassle to put together slides. So it's nice just to be able to talk, and of course I like talking, so this is all good. So thanks very much for having me and putting this together. And I think this is a great little forum, and I'm glad you guys do them. So for those of you on the phone, maybe I've met some of you. I know I met some of you at the NYU course this week in New York who said you'd be listening. I wanted to first start just giving some brief overview for 10 or 15 minutes about bronchiectasis and NTM, and then take some questions about those entities, and then I think we're going to come back and talk more about how to diagnose and treat those conditions. So I assume that many of you on the phone have these conditions, one or both, and you're experts, you're pros, and that's the nature of this condition. These are chronic, lifelong conditions, lifelong after they occur anyway, and individuals really do become pros in terms of how to manage their disease. And they become such important partners in terms of disease management, because I rely on all you guys to help all my other patients who are new to this figure out how to do it. So please keep that up, and it's really helpful to everyone the more people share with each other. So as you know, bronchiectasis is this inflammatory condition. It's an inflammatory airway condition. I think about it similar to rheumatoid arthritis. It's an inflammatory joint condition, or inflammatory bowel disease. It's an inflammatory bowel condition. I mean, there are certain organ systems in the body that are chronically inflamed for whatever reason, and this presents a problem, both symptomatically as well as potentially with regard to damaging that organ long term. So in the airway, we call this bronchiectasis, and the word is literally bronchial, which is the Latin for tube, and ectasis, which is Greek for stretched out. And someone put these two words together. Bronchiectasis means a stretched out air tube. And rather than that being a nice tight cylindrical apparatus, it has become gradually stretched out, and the airway wall has become thinner. It's dilated, and it gets floppy, and what drives this ongoing transformation and damage is inflammation. So in some cases, that inflammation may have an autoimmune root, such as in rheumatoid arthritis. About 10 or 15% of people with rheumatoid arthritis will have inflammatory lung disease. In other cases, it's driven by genetics. I mean, the classic is cystic fibrosis, and of course, there's the CF or cystic fibrosis that we all know of young children being diagnosed with CF. But there's this whole other pool of people out there that have variants of CF and much less aggressive forms of it, and such that they don't manifest it until much later in life. And certainly some of the people we see with non-cystic fibrosis bronchiectasis actually have some sort of mild variant of actual CF, and it's just not ever diagnosed necessarily. Then there are a whole group of people that just they don't have a variant of CF. They have some other reason for this. There are a group of people who have infections, either when they're young as children or later in life, that actually damage the airway. It could be a pneumonia, or it could be a bacterial infection. It could have been TB. It could have been any type of infection in the airway. If it's aggressive enough or prolonged enough, it can leave a resulting damage to the airway. The airway can enlargen, it can scar, and once that airway is bronchiectatic or dilated and damaged, it can then collect further bugs from the environment in the future. And these are bacteria, mycobacteria, fungi, pollutants, particulate matter, anything that you breathe in during the day. You don't always breathe it back out. Sometimes it gets stuck in these areas, and particularly these areas of damage. And what we see in those areas of damage is, again, thinned airway wall, and the cilia, which are these little tiny hairs in the airway that tend to beat one direction. Those are our evolutionary answers to having basically a cleaning system for our airways, where those beat one way and help, along with the mucus, help grab stuff that has come into the airway and help flush it out. And gradually this stuff works its way out, but when the airway is damaged, that system breaks down. The cilia are damaged, they don't work. The airway pools with mucus or biofilm or gunk, whatever you want to call it, but I always liken it to the sink pipe. If you take your sink pipe apart and look inside under it, you see all the biofilm or gunk lining the pipe, and you can't really get rid of that unless you scrub it with a toothbrush. You can run the bleach through it until the cows come home, but you're never going to get rid of all those the organisms living there. You're never going to sterilize the pipe unless you really brush it out and scrub it. And that's the same thing that's happening, or the same type of phenomenon that's happening in that damaged airway. So that biofilm can harbor a number of organisms, including NTM, or non-tuberculous mycobacterium. So I'll launch into NTM in just a second, but I will say that is a bug that can cause bronchiectasis. It is one of the infections that can actually cause the condition to occur. I think most people have the condition for some other reason, and then organisms such as NTM are inhaled from the environment and get stuck there and cause more problems. I think that's usually the case, but there is certainly the case where it's the opposite, where actually an infection is what starts the bronchiectasis, and that infection could be NTM, could be TB, it could be strep pneumo, it could be any infection, and it could have been acquired as a young person or later in life. So to finish the story about bronchiectasis, there are other, of course, causes for bronchiectasis. Some of them are quite rare. Primary ciliary dyskinesia, PCD, I mean, that's a condition where those cilia, those little fine hairs I was talking about, they just don't work. And so again, you see mucus buildup and biofilm buildup and inflammation and gradual destruction of the airway. There's another of other conditions. COPD, there is a certain percentage of people with emphysema and COPD or smoking-related lung disease who develop some amount of bronchiectasis. There are people that develop because of immunoglobulin deficiency. Presumably that's just because those type of people have had many small or large infections in the airways, and it just gradually causes damage to the airway. There's other conditions. I could give you a list of things that are hard to pronounce. The bottom line is about 50% of people with bronchiectasis, they don't have any condition, and we don't really know why they have it, and we call that idiopathic bronchiectasis. Idiopathic is one of those great words in medicine, meaning we don't know what caused it, and so a lot of things in medicine we just say are idiopathic because we don't know what caused it. And then someone says, maybe it was a virus. I don't know. I mean, the bottom line is we don't have it all figured out, and there's a lot of things we still don't understand why they happen. So for about half the people with bronchiectasis, there's no identifiable cause. So what about the bugs of bronchiectasis? So like I said, you get this buildup of gook in there, and many times, organisms are driving the inflammation and the buildup of the biofilm and the airway damage. One of the most common ones that we're finding more and more is NTM, and NTM stands for non-TB mycobacterium. In the world of mycobacterium is tuberculosis, and then there's all the other ones, are the non-tuberculous mycobacterium. The most common is Mycobacterium avium complex, or MAC. It's also called Mycobacterium avium intracellulare, or MAI. You'll often hear people like me use MAI and MAC interchangeably, and that's because it's a complex of species. Avium is one, and intracellulare is the other. They're very closely related, and so people have just lumped them together as a complex, so we call it either MAI or MAC. That's the most common cause of NTM lung disease. These bugs are ubiquitous in the environment. They're in water pretty much everywhere, and they're in soil pretty much everywhere. So they're very hard to avoid, and presumably we all come in contact with them probably on a daily basis. For whatever reason, about 2/3 or 3/4, somewhere in that area of people with NTM lung disease also have bronchiectasis. And as I said before, it's a chicken or an egg kind of thing. Bronchiectasis can be what sets someone up to later acquire NTM disease. However, the reverse is also true. People can get NTM infection first, and then that causes bronchiectasis. So they do go hand in hand. There is a number of other people that get NTM disease, but they don't have bronchiectasis. Most of those people have emphysema and COPD. And then there's a variety of other underlying lung conditions that also put people at risk for acquiring environmental infections like NTM. Interstitial lung disease, sarcoidosis, pulmonary fibrosis. I mean, there's lung cancer. I mean, there's a number of things. At any time when the architecture of the lung has been altered, then certainly there's a risk for acquiring things from the environment, such as NTM, and again, most commonly MAC. The other NTM to mention is Mycobacterium abscessus. It's probably second most common in the U.S., along with Mycobacterium kansasii. With those three species, that's probably about 99% of the NTM lung disease in the U.S. And there's a pretty short list of a few other bugs that we tend to treat. There's 176 NTM species last time I checked, but probably only about 10 of them cause lung disease, and at least in any sort of numbers, so that we're able to find these cases and measure them. In terms of symptoms, well, the symptoms are the same, whether you have bronchiectasis alone or bronchiectasis with NTM. I mean, certainly bronchiectasis itself has been described as a vicious cycle or a vicious circle. And it's that circle of inflammation and infection. And you get an infection, you increase inflammation, it causes damage, you treat it, it gets better, and then it comes back again. It's because we can never really fully eradicate most of these organisms, it's a complicated little ecology in the airway. In that biofilm or that gook, there can be, really a multitude of species of different organisms living together. And I tell my patients it's really more about balance. It's not about what's in there. It's more about how they're living together. And you know how it is on Earth when countries and humans are actually treating each other nicely and living together nicely and peacefully, then everybody's happier and the world's a better place. The same thing is in your airway. And when all these different constituents, these bugs, are actually sharing resources and enjoying each other's company, people seem to have fewer symptoms. And that's because there's less inflammation. So, a lot of what we do with bronchiectasis, and I'm going to get to therapy later, but a lot of it is managing these symptoms, and a lot of it has to do with prevention of new infection or trying to keep the populations of resident bugs happy and at lower levels, because there tends to be less inflammation when that's the case. Most people have chronic cough. Many people produce mucus on a daily basis, although a good percentage of people have no mucus. They can't get their sputum out, or they just don't have any. And some people lose weight with these conditions. Some people have quite a bit of fatigue with these conditions. And I think the fatigue is, again, it's attributable to inflammation. The weight loss is attributable to inflammation. The more inflammation you have, the harder it is to feel good and the harder it is to keep your weight on. To me, those are probably the top symptoms I see when patients come in. And again, it could be just bronchiectasis on its own, and you maybe have Pseudomonas in there. You maybe have Stendotrophomonas, alkaligenes. I mean, there's a whole list of bugs that tend to colonize patients who have damaged airways. But you also might have NTM, and certainly NTM tends to be one of the more progressive and damaging of those infections on a long list here of different species I could name for you. And so when anyone comes in and they're feeling worse and they're declining, we want to rule out potentially NTM. We want to look for Pseudomonas. We want to look for a few of the other bugs that tend to cause a lot more inflammation. So that's probably meets the agenda for the first part of this talk in terms of a brief overview of the conditions, their natural history, and the symptoms. And I think I'm happy to take any questions at this point.
Great. Thanks, Dr. Winthrop. This is Delia from the Foundation. Before we open it up for questions from everyone on the line, I did want to ask you, what can patients do in order to avoid NTM lung infections? Do you have any recommendations?
Sure, that's always a question each patient asks, and it's a good one. The answer is move off Earth. I don't know. Live in a bubble. I mean, I really don't get very tripped up on this question because I don't think there's a lot that people can do. I think these bugs are ubiquitous, meaning they're all over the place, and I think you got to live your life and do the things you want to do. So I mean, there's a couple things I tell patients to avoid because they're fairly easy, like hot tubs is one, steam saunas is the other. And aside from those two things, I don't really tell people to do anything because they need to walk around outside. They like to garden. They like to swim. They need to take showers. They need to take baths. I mean, they need to do most of these things in life, or they want to do them because they have pleasure doing them. And so I really think, if you can take off the table some of the really high exposure zones, and really those to me are anything where, like hot tubs or saunas or steam, anywhere where there's steam and saunas and just lots of aerosolized hot water, that's what I tell people to avoid. If you want to quit power washing, that's great. Don't power wash. Have your spouse do it. I think, I actually, for the gardeners, I tell them to avoid busting open those bags of potting soil. and peat moss, have your spouse do it instead. And I have a few patients that ride horses, and they like to clean out the horse barn, with high, big jets of hot water. And I tell people, again, have your spouse clean out the horse barn. You're done. Other than those things I just mentioned, I don't really tell people to avoid things. I mean, there's a lot of people that get into the filter idea. I know patients that are filtering their water, they're changing their shower heads every 3 weeks, and I don't know that any of those things help. I think, if you're building a brand new house with brand new piping, then, potentially, installing a UV filtration and UV system at the very start of your house's pipes so that the water coming in from the city can be filtered and sterilized at that point. Maybe that would work because you have brand new pipes. But for 99% of us, we're living in houses with old pipes and lots of biofilm, and there's probably MAC in the pipes, and it's been there for years. So it's hard to really avoid these bugs, and I think some people probably spend more time trying to avoid them, and they get too stressed out and worried about it. And I think it's better just to go, live your life and enjoy it.
Great, thank you.
That's my philosophy
anyway. Great. So I will ask Kathy to open it up for everyone else who may have questions.
In order to ask an audio question, please press star, then the number 1 on your telephone keypad. Again, that's star 1. We'll pause for just a moment to compile the Q&A roster.
Thanks, Kathy.
Your first question comes from the line of Lisa Cotlin.
Hi. Thank you for having this talk. My question is, with the stomach, with the gut, like people take probiotics to kind of keep the bacteria populations under control. Has there been any research about like introducing something or like a way to, besides antibiotics, keep the bacteria in the lungs under control?
Yeah, so you're kind of looking for a probiotic for the lung, correct?
Correct, yes.
Well, I am too. I think that's theoretically a really interesting idea and potentially beneficial idea. I don't know of anyone working on that actively. It's a little bit, to be honest, it's a little bit difficult to work on. How do you put quote unquote good bacteria in the lung? That's one problem. So you could inhale in some way. We could probably figure that out. The other problem is, from an experimental standpoint, you're basically giving someone a lung infection, and you hope it's going to be okay and safe, but you don't really know. So, it's something that would be possible to evaluate, but it would take some time and some really careful studies, and probably best to be done in certain animal models first to make sure it's not harmful. And it may be one of those things where it's harmful for some people and not for others, and it may depend on what's in the lung already. So it's pretty complicated. You could see the potential downside. If one person has a bad reaction and dies or gets worse or something, it could be a big problem. So it's pretty risky in terms of a development program, to invest in doing that right, and yeah, I think it's really risky. So I'm not sure it's going to happen or anytime soon. Do I think it's a good idea though? Yeah, I do, because that may be the answer. It may be that we need good bacteria, quote unquote, to be in there to control and police some of the other ones. So I don't know. I don't know when that's going to happen, but if you want to take it on, that would be great.
Thank you for answering my question.
Yep.
Your next question comes from the line of Reagan Enslund.
Hi, I am curious. I've heard a lot about how dairy products, cheese and milk, contribute to mucus in the body, and I'm just wondering if you recommend to your patients to cut back on dairy, if there's any science behind that.
Yeah, it's interesting. You know, I've been having a lot of postnasal drip lately, and I've actually increased my dairy, and it went away. So there you go. I don't know. I mean, I certainly have lots of patients that think that dairy products, you know, thicken their mucus, and it seems to be more kind of upper airway stuff, like coming from their nose, their sinuses. Although I do have some patients that think it causes their sputum to change. It wouldn't surprise me if that's true. I mean, I think, you know, you are what you eat, and I don't think it's necessarily dairy. I think it can be anything. I think different things you eat can change your microbial flora in your gut, and probably, I mean, it's potentially true elsewhere, like in your airway. So it wouldn't surprise me. I guess my answer back would be that I think it's just a case by case. Everyone's different, and like I just told you, for me, I mean, it seemed to help my mucus. I have patients who have diarrhea, irritable bowel. You know, you give them antibiotics, it gets better. You have other patients, you give antibiotics, it gets worse. And it probably just depends on, you know, what they are colonized with already and what their flora is already, and then how that intervention, you know, that dietary intervention or antibiotics, whatever you're using, you know, changes that flora. And in some cases, it probably changes it for the better, and sometimes it probably changes it for the worse. So, you know, I'm all a fan of the patient trying out, you know, avoiding dairy if they think it's a problem, and see if it helps. And sometimes it does, sometimes it doesn't. You know, the one thing is about dairy, I pretty much advise all my patients to get heavy on dairy. However, I think everyone should eat a bowl of ice cream every night. I mean, not everyone, but these patients should. I mean, most of my patients are, their inflammation rate is high, they're deficient in calories and protein, and they need supplementation. And, you know, one of the greatest ways to supplement for calories and protein is dairy. It doesn't have to be dairy. It's just easier because that's what it is. But it certainly could be other things too. Anyway, so I'm not sure I answered your question, other than I think it's worth, you know, trying one way or the other just to see if it modulates things. But I do think it's different for different people.
Okay, thank you.
Your next question comes.
Oh,
go ahead.
Sorry, yeah, I just wanted to say we can take one more question and then we can continue with the program. Thank you.
Okay, your next question comes from the line of Carol Goldstein.
Hello.
Hi, Carol.
Okay. All right. I've had bronchiectasis for many years, and I was put on a treatment 4 years ago by Dr. Charles Daly at National Jewish Health in Denver, a nebulizer with 7% sodium chloride and an aerobica attached to it to clear my lungs once every day. And it has reduced the Pseudomonas to very, very rare amounts of Pseudomonas. I have not had an exacerbation in over 4 years, whereas I used to have exacerbations every year to year and a half with PICC lines and heavy-duty meds. And this has turned my life around, and I wonder about that for other bronchiectasis patients. I also was put on azithromycin, 250 milligrams 3 times a week. That I was started in November of 2010. And those two things have really restored me. I sterilize the nebulizer and the aerobica every day in one of those Medela bags in the microwave, and it has really turned me around. The other thing I was put on to put weight on was called Scandi Shake, S-C-A-N-D-I Shake. It's a powder that you mix with 8 ounces of whole milk, and it's supposed to give you, I think it's 800 calories per glass. So those are the two things I wanted to share.
Yeah, so I mean, that wasn't a question, but that's a great comment, and thanks for sharing it, because I agree with Chuck Daly is a close friend of mine, and I agree with almost everything he says, except for, he roots for the Colorado Rockies. I disagree with that. However, there's no question hypertonic saline really helps a lot of people. I think there's not a lot of studies where it's been studied, but there is a certain subset of people with bronchiectasis where it can be very helpful. I think there's also people where it doesn't help much, and not everyone is willing to do it or take the time to do it or can do it or tolerate it. So I think it's often something we try, and if it works out, then that's great. And obviously it has for you, which is fantastic. And the azithromycin therapy too is something more and more that we're trying to use. I'll just tell you that the complicating factor with the azithromycin is that, people with bronchiectasis are at such high risk for getting MAC, and it's probably, something like 15% of people with bronchiectasis will get MAC at some point in their life. Maybe it's lower than that. I don't know, 8 to 15%, 10%. It's somewhere in that ballpark, and it doesn't always mean it's a problem, but they might acquire it, and it may, hang out there for a long time without doing a whole lot. The problem is if you put, everyone with bronchiectasis on azithromycin, a certain percentage of people are going to have MAC, and then you're going to breed azithromycin-resistant MAC, which is a big problem potentially. And so you have to be really careful when you select your patients to put on azithromycin for their bronchiectasis. And the way it works is it's just kind of an anti-inflammatory. It's an immune modulatory agent. I mean, we don't quite know exactly how it works, but it does diminish the inflammation, and it does decrease the need for other antibiotics to treat exacerbation. So it can be a really useful intervention, but you just have to be careful, and you've got to frequently monitor your patients for NTM, like MAC, to make sure they don't have it or they're not getting it while they're on the azithromycin. Probably being on it might help prevent you from getting it, although I don't know that. That's something actually we're trying to study right now. But those two things you mentioned can be very useful.
Thank you.
Great. I think we can continue with the program now, Dr. Winthrop, and then we can open it up for more questions and answers after this next segment.
Sure. So just a few words about treatment. Let me just start with bronchiectasis on its own. So I think two of the treatments we just covered, which was fantastic. So, the idea that you can do quote-unquote pulmonary hygiene, that's what we call it, or pulmonary toilet. I have no idea why they came up with that term years ago. But the bottom line is, how do you keep yourself clean, and not just the outside of your body, but the inside too? And so, of course, your airways are connected to the outside world. And so they, again, like I said before, can collect things from the outside world. So the idea that you're going to move stuff out, and again, those damaged airways have a hard time doing that. So we have lots of different things called, the aerobica or flutter valve or a cappella valve. I mean, there's a number of valves that give you what's called pository expiratory pressure. So when you blow into those valves, it actually puts positive pressure back in your airway, and it vibrates the airway very subtly. And that vibration and pressure helps knock things off the airway wall, and then theoretically helps you, cough or move those things forward. That is one way we, have people do airway hygiene. And I think the importance of airway hygiene cannot be understated. It's really important. The other way to accomplish this, and the best way, and probably the best thing for everyone, is exercise. And that's aerobic exercise and posturing exercises. If I could get every patient I had to do, 30 minutes of aerobic exercise 4 days a week, and on the other 3 days a week do yoga or Tai Chi or some sort of posturing exercises, Boy, do I think that would help. People will clear more secretions. The posturing stuff helps you drain. The aerobic exercise gets your breathing rate up, which helps to scour out your airway and clear secretions. You know, there's a good chance that that would keep, you know, half of these people out of trouble in terms of not needing antibiotics for exacerbations or not needing antibiotics for NTM. Of course, not everyone can do these things. They're physically, you know, they can't, you know, they got arthritis, or they're too old, or, you know, whatever the case is. But the more of that you can do, the better. And I have a lot of patients that they have a stationary bike, they have a rowing machine, they get in the pool, they do water aerobics, whatever it is, they do something to get their breathing rate up and their heart rate up for 25, 30 minutes a few times a week, and it really, really helps. So that's kind of airway hygiene. We have these devices. We also have the vest. I should have mentioned that. I mean, that's another way to, you know, again, promote stuff being knocked off the airway wall so you can move it forward with the cough. So these techniques, I think, are really, really important, and that's the starting point for anyone with these conditions, is to figure out an exercise regimen that they can do and benefit from, and then, you know, figure out what other hygiene measures they need, and whether it's a valve or a vest, or whether it's the hypertonic saline, 7% or 3%. I mean, these are all tools that I think really need to be utilized before we start thinking about antibiotics. The next line of tools are the antibiotics, and the way they work is, of course, they kill bugs, and, you know, sometimes that actually causes a temporary upswing in inflammation, and people actually feel worse the first few days or first few weeks, depending on what we're treating. You know, if you're sick and having exacerbation, then of course we use antibiotics. You need to treat those, and those can be oral, they can be IV, occasionally they're inhaled. We tend to use inhaled antibiotics really not for treating exacerbations, but for preventing them. And the idea with inhaled antibiotics as a preventive really comes from the cystic fibrosis world, where they've been shown to be beneficial. In our world, the non-CF bronchiectasis world, there are hints from a number of studies that they help, and but unfortunately none of the studies have really come out positive enough to result in FDA approval of anything. So most of the antibiotics we use are off-label, so to speak, and, you know, we extrapolate from that data that we have in this setting as well as the data from the CF setting to say, hey, we think they work. Anecdotally, I mean, I certainly have a number of patients on inhaled antibiotics, and it breaks their cycle of infection, and it's really important for them in terms of keeping them out of the hospital or keeping them from having another exacerbation. In terms of NTM, the treatment's a lot more prolonged. NTM just, you know, it's important to know that NTM grow really slowly. They're totally different than Pseudomonas and all these other bacteria you may hear about. They grow much more quickly. And those bacteria cause, you know, exacerbations. You know, you start feeling bad, you feel like you got a cold, and, you know, a few days later you feel like crap. NTM doesn't do that. NTM makes you feel like crap very, very slowly over the course of months. And it's often in the context of other exacerbations from other organisms that you're treating. The patient feels a little better, but never quite getting back to baseline. And, you know, after several months, it's pretty clear there's kind of this slow slide going on. So, you know, NTM can be hard to diagnose. They're hard to find. They don't necessarily grow as well in culture as those other bugs I mentioned. People often don't produce enough sputum to really look for them, and they progress so slowly that they're hard to diagnose. I mean, some of you probably know we're trying to make a blood test here at OHSU as part of our research program. I mean, we have a blood test for TB. We should have one for MAC, and I think we're getting close. We're getting some really interesting results, and I hope to have a test that we could use in a few years where, help people get diagnosed earlier and it help people be monitored during their therapy. CT scans are really important. X-rays often aren't sensitive enough to show these infections or this condition of bronchiectasis, and the CT scans are really key for diagnosis. So, sometimes if the sputum isn't available or if it's not culturing out anything and we're pretty convinced there's something going on because of the patient's symptoms and their CT scan looks like it, then a bronchoscopy is done. I'm sure many of you have had bronchoscopies where the pulmonologist sticks a tube down your airway and squirts a little water around and sucks it back and cultures it. And that can be a very important diagnostic tool. So, once NTM's diagnosed, not everyone's treated. I mean, we've done studies and others about 1/3 to 1/2 of people with this condition are treated in their lifetime. The other half never need treatment, and it's the case where many times the infection's very, very mild, and it's indolent, meaning it doesn't really progress much. And I have had patients with stable symptoms and stable CT scans for decades, and they've never needed therapy. On the flip side, there's maybe, 10 or 15% of people that progress much more quickly. In 6 months, they are developing lots of lesions in their lungs, and the MAC is causing cavities, or, Mycobacterium abscessus is a much more aggressive bug usually. We tend to see quicker rates of progression, but not always. And so, when these things are occurring, these people obviously need therapy. And so the treatment is generally, for those of you who have done it, you know it, we usually start with 3 antibiotics. Azithromycin and rifampin and ethambutol would be the most common. But, 3 antibiotics from those classes. And sometimes we had an IV called amikacin. And sometimes we use surgery after, 6 months or more of therapy. We might try to resect some of these areas. Most people don't need surgery. Most people do just fine on these antibiotics and respond to them. You often have to take them for a year to a year and a half, sometimes longer. There are some people that just need lifelong antibiotics to keep the MAC suppressed and keep it in check. And everyone's different, but most people will need something periodically anyway the rest of their life. And when I say most people, I mean, that 50% of people that ends up being treated. The other half that never end up being treated, they either just luck out and they don't have a very virulent strain in their lungs, or, their airway hygiene and exercise is enough to control it. I'm a big believer in vitamin D, and I don't think you need extra vitamin D. I just think you need to be replete with vitamin D. You need to have a normal level. And the reasons are your macrophages, or your white blood cells in your lung, that gobble MAC up and kill it. They kill it with a vitamin D-dependent enzyme. And so if you're deficient in vitamin D, probably that enzyme is not there enough, or it's not working efficiently enough, and there's there are studies using these cells in a test tube that show they work better when they have enough vitamin D around. So I think that could also be an important tool for keeping people stable. And lastly, I'll just say there are some new therapies in the pipeline. There's a new inhaled form of amikacin that's not yet approved, but we just completed the phase 3 trial, and it looked positive, meaning it helps people. We have another trial with Mycobacterium abscessus that we're running, looking at that agent. There's several other agents where there are trials being planned or at least talked about, and I'm pretty hopeful that in 5 years we'll have a new treatment paradigm, and that we'll have 3 or 4 other types of antibiotics to think about, or at our fingertips, that we can use if we need them. And finally, what are the resources available for patients? Well, you're kind of talking to the resources right now. It's COPD Foundation and NTM-IR. I mean, those are those are the patient resources for patients with bronchiectasis and for patients with NTM. And they're phenomenal organizations in terms of being our partners for research, and particularly patient-centered research, which I'm a big believer in. And you know, they are sources for patient educational materials, support groups, and whatnot, and social websites where people can exchange information and learn about their condition. And I think this has been, you know, all kind of in the last 5 to 10 years, this stuff has evolved, and it's good it's here because it's an important resource. And lastly, you know, when drugs get approved and companies have drugs for these things, they often put money into developing patient resources as well. So I think that's probably what's in the pipeline as we hopefully see some drugs get approved. And I think now we're at the time for more questions and attempts at answers.
Yes, Kathy, would you open it up for questions, please?
In order to ask a question, please press star, then the number 1 on your telephone keypad. Your first question comes from the line of Cara Lures.
Hello? Hello?
Hi there.
Yes, hi. This is a wonderful, wonderful conference. I happen to have bronchiectasis and MAC, and I do all the good things, like I swim in pools and don't worry about anything. I take showers and don't worry about anything. But recently, I train animals now that I'm retired, and recently people have been asking me to train their birds. And in training their birds, of course, I'm cleaning out all the birds' cages and so forth, and the thought occurred to me, my goodness, birds can carry MAC, and I wonder if this is, if I ought to just pretend I'm swimming and not worry about it. The birds all look healthy, but there's a lot of time and a lot of closeness to the bird and a lot of bird cleaning going on here.
Yeah, you know, I don't know if people getting the avian strains of MAC. I don't know that happens actually. I mean, the name of the bug, you know, is reminiscent of avian. It's avium, and there are closely related strains that are in birds, but I don't know if the bird strain's actually getting into humans.
Well, I tried looking all over the place on the internet. I couldn't find out anything about it.
Yeah, I mean, that being said, I guess it's possible. I think anything's possible, but I probably wouldn't worry about it. You know, I wouldn't, you know, take a high-pressured sprayer to a bird cage and, you know, take a deep breath while I was doing it. I'd probably avoid those type of things, but I think, you know, just routine cleaning should be fine. I mean, I assume you're wiping things down and not necessarily causing a lot of aerosol.
Yeah, you do give birds a bath now in their cages, especially if they can't fly, with spraying them with water. So they're spraying it.
Well, I mean, you know, the spray of the water, you know, is always an, you know, potential concern. But again, I mean, I doubt you're going to expose yourself to much. And I mean, it's certainly going to be no different or no more than your shower. And I wouldn't worry about the birds themselves. I don't think they're going to give anything to you.
Okay. I haven't been, but I just thought I'd ask. And one quick question. Who in the United States do you think is doing most of the studying of bronchiectasis, most of the research?
We are.
Are you?
No, you know, there's a bunch of us, and the nice thing is we're all friends and we all work really well together. You know, there's probably 15 or so researchers spread throughout the country that are working either, you know, collectively as a group or, you know, small groups. And the COPD Foundation and NTMIR both sponsor a registry called the Bronchiectasis Registry, which you may be in.
Right.
That registry has, I don't know, 2,500 people in it, patients, but it ties us all together as researchers, which is really nice, and it helps us collaborate on projects. And on the NTM side, we founded an NTM research consortium a couple years ago that that contains a number of the same researchers, although not all the same, and then some others outside of that network. And we hold an annual meeting, and we write grants together, and we try to pursue studies together, and we are. I mean, we have a number of studies going together. And so I think, you know, those those two networks are and again, there's a lot of overlap between them, but that's where most of the research is going on in terms of the academic setting.
The reason I ask this question is that most of us now are getting pretty old with these diseases, and I'm particularly interested in bronchiectasis because so many of us have that.
Yeah.
And we might be looking around for places to leave some money to make sure that good research continues for particularly bronchiectasis. What would you do?
I would just write a big check to OHSU in Portland, Oregon. No, I think that's a wonderful sentiment that you just voiced, and I think it's really important. You know, I think most of us as researchers, we're in a field that have had no industry support and basically no government support.
Right.
Ever. And we've been banging our heads against the wall and for a decade or more to try to get research funds and to try to advance the science so that we can better care for patients and prevent this as well. And, you know, I'd say the last 5 years, things have started changing. The government's become interested, primarily because industry's become interested. And there's a few companies that realize that there's, you know, an unmet need here and a potential way for them to, you know, make money and help people, which is what they want to do. So, you know, once industry starts getting interested, then, well, the government has to because FDA is getting involved. And then FDA says, geez, we don't know much about this. Shouldn't we learn more about it? And, you know, and the companies say the same thing. We don't know much about it, but there seems to be an unmet need, and let's figure it out. So I think those two factors have really helped bring, you know, it's certainly we're getting grants now that you know 10 years ago we weren't getting. No one was interested, and so I think it is helping all of us do more research. My only advice to you would be to probably, you know, give to, you know, groups that have been personally important to you, and if you have relationships with, you know, people or researchers that you know have been, you know, important to you personally or to friends or something, then, you know, that's probably what I'd do. I'm sure NTMIR and COPD Foundation would probably, you know, welcome support as well, and I'm sure any of us as independent researchers would welcome it. I do think it is something. It's great you brought that up. It's something that it's not like something you know you try to like bring up with your patients or anything, because everyone's spending so much money on their healthcare to begin with. You know, you don't want to ask someone to donate money to your program. But I mean, I have a number of patients that have been wonderful that way, and I think probably all of us have. And you know, that money does not go unused. It definitely goes to help further the science and for patient care. You know, really patient-centered research, and I think it can be really, really important. So I would just, like I said, I think I'd just encourage you to think about who's been important to you and you know, where you feel most meaning in giving. So.
Thank you very much for doing all of this. This has been a wonderful, wonderful conference.
Great, thanks.
Great, thank you. Kathy, I think we have time for one more question, if that's okay with everyone.
Your next question comes from the line of Eleanor Reckel.
Hi, doctor. Thank you for sharing your expertise with us today. I have two little questions. One is, being a patient having bronchiectasis and NTM a number of times, are you in favor or do you believe it's important to have a flu shot and a pneumonia shot?
Yeah, those are great questions. You know, if you have this underlying lung disease, as you just mentioned, you're definitely at much higher risk for not just getting pneumonia due to strep pneumonia or influenza, but also having a poor outcome, meaning, you know, ending up in the hospital or even dying from it. And it's definitely important to do whatever you can to prevent that. You know, the flu shot, I mean, I would definitely get every year. I mean, I get one. I don't have underlying lung disease. I mean, I definitely, if I had it, I would get 2 a year. No, I'm joking. I don't know that 2 a year will help, but you know, we need a better flu shot. I mean, that's an area of avid research. I do a lot of vaccine research, and so do lots of other people. And I think, we all want to make better vaccines. The flu vaccine is sometimes very effective, and some years it's not as effective, and that just has to do with, whatever strain. You put a certain number of strains in the vaccine, and you hope those are the ones that come to your region that year, but you never quite know, and you're taking a guess. So eventually we're going to have a vaccine that really isn't strain dependent, and it's going to, build immunity to our other parts of the virus, and it should be more effective. But, I don't know how long that's going to take, probably in the next 5 years. But I would still get that flu shot. I mean, it's on average 50% effective every year. Theoretically, it halves your chance of having the flu or even having a bad flu. So I think I'd get it. The pneumonia vaccine is a bit more complicated because there's 2 vaccines out there. There's the Prevnar 13, the one we've been using in kids forever, and now we're using it in adults. And there's Pneumovax, and probably a lot of you have had Pneumovax, and we've been using that in adults for years. And some of you may have had Prevnar now as well. But the way you're supposed to use those vaccines are actually in combination. I mean, if you've never had one, you should start with the Prevnar, and then sometime in the next year get the Pneumovax. And the Prevnar basically protects you against 13 strains or serotypes of strep pneumo, and the Pneumovax protects you against 23. So if you get the Prevnar first, what it does is it boosts your responses to the 23 serotypes when you later get that vaccine. It's kind of it's a 1-2 combo, and that's how we're using those vaccines right now. That may change as time goes, but I would definitely make sure you've had both those vaccines in accordance to the recommendations.
I had the pneumonia vaccine probably 8 to 10 years ago, never having had pneumonia in my life, and then I had the pneumonia shot and had pneumonia twice after that.
Yeah, unfortunately that happens. Was it strep pneumonia or just pneumonia?
I think it was, you know what, I can't even answer that.
I mean, here's the deal, and that's why, I mean, it's kind of confusing, but the pneumonia shot, Pneumovax, it protects you from strep pneumonia, and that's it.
Mm-hmm.
And there's about 20 other bugs that cause pneumonia, and strep pneumonia just happens to be one of the more common ones, and also one of the more deadly ones. And so that's the one that we have a vaccine against. It also, I mean, strep pneumonia is more likely to become invasive and go in your bloodstream or your central nervous system, and it's just devastating to small children. And so that's why these vaccines, arose really, because this can be a really bad bug with bad outcomes. The other bugs that cause pneumonia can also be bad and have bad outcomes, but we don't have vaccines to most of them. So when you get the strep pneumo shots, it does protect you from some pneumonia, but probably only like 30 or 40% of it.
All right, well, at least something. Just one other quick, I hate to keep you, what's bothering me, that when you take antibiotics a lot, and I've had a lot of antibiotics, doesn't that also kill good bacteria as well at the same time?
Yeah, it can. I mean, that's always one of the tricky parts. And not always, because some antibiotics affect, lots of different kinds of bugs, and some of them are much more narrow in terms of which ones they kill. And so, some kill more, quote unquote, good or harmless bacteria than others. But yeah, and I mean, I think our big concern just with antibiotics in general long term is the bugs that you're trying to kill. The more you use that antibiotic, the more likely those bugs will eventually become resistant to it. And so, I mean, this is just Darwinian natural selection on fast forward, where you have a selective pressure, which is the antibiotics, and the bugs that are naturally having mutation or resistant are going to be the ones that survive it. And so eventually you just end up breeding one of those populations. It's like if all of a sudden we went in the ice age, all the animals with fur are going to survive and the ones without it are going to die, right? So it's the same thing that's going on in your lungs. So limiting antibiotic use is a really important thing. And we try not to, and when we use our antibiotics, we try to use them in ways that diminishes the chance the bugs will develop resistance.
Right.
And that's kind of a whole nother lecture on its own. But that to me is probably the biggest worry with the antibiotics.
Okay, I really appreciate your responses. Thank you so much.
Yeah, thank you guys. Happy holidays.
Great. Thank you so much, Dr. Winthrop. I just wanted to say thank you on behalf of the COPD Foundation. I hope that everyone has found this teleconference helpful. And if anyone still has unanswered questions, I would encourage you to sign on to our online community, which is Bronch and NTM 360 Social. There's a section there specifically for questions and answers, and you can access that website by reaching www.bronchandntm360social.org. I'll repeat that one more time. So it's bronchandntm360social.org. And within the next week or so, everyone on the phone can expect to receive a follow-up email from us at the COPD Foundation. And the follow-up email will include information about helpful resources. We'll include a link to the NTMIR website as well as our website. And it'll also include a link to a survey that will allow you to provide us with feedback on the event and suggestions for the next event. So in the meantime, I'd just like to thank you again on behalf of the COPD Foundation, and I wish you a wonderful holiday season ahead. Thank you.
Thanks, guys. Have a good one. Thanks.
This concludes today's conference. You may now disconnect. 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 You may now disconnect.